Hello everyone, welcome to the channel, and welcome to the third question about acid-base disorders. Now before we begin, I'd just like to say, do give this video a like, and do subscribe to the channel. Alright, without further ado, an 8-year-old girl is brought to the emergency department with abdominal pain, vomiting, and increasing confusion over the past day. Her mother reports that she had a viral upper respiratory illness 4 days ago, followed by increased thirst and frequent urination. Over the last 12 hours, she has become progressively lethargic. Upon examination, she is drowsy but arousable, with dry mucous membranes and sunken eyes. Her breathing is deep and rapid. Her breath has a fruity odor. Her vitals are 99 degrees Fahrenheit. Her heart rate is 128 beats per minute. Her respiratory rate is 32 breaths per minute. And her bedside BSR is around 480 milligrams per deciliter. Moving on to the laboratory findings, she has a pH of 7.12, the normal being within 7.35 to 7.45, a sodium milliequivalent level of 132, the normal being between 136 to 146, a bicarbonate of 8, the normal being between 22 to 28, a chloride level of 96, the normal being between 95 to 105, a partial pressure of carbon dioxide of 25 millimeters of mercury, the normal being within 33 to 45 millimeters of mercury, and a potassium level of 5.4, quite high, the normal being between 3.5 to 5. Which of the following best describes this patient's acid-base status? Option A, primary respiratory alkalosis with metabolic compensation. B, normal anion gap metabolic acidosis due to bicarbonate loss. C, high anion gap metabolic acidosis with respiratory compensation. D, metabolic alkalosis with respiratory compensation. E, mixed metabolic acidosis and respiratory alkalosis. I'll give you a few moments to answer this question. And you could also pause the video and answer it yourself. Alright, if you picked option C, high anion gap metabolic acidosis with respiratory compensation, you'd be correct. Now, before we go into the explanation, first we must diagnose this patient. Now, I deliberately left out the diagnosis in this question because that's what the USMLE will do. They'll sometimes let you come to a diagnosis first and then extrapolate what the further treatment plan would be, what complications there could be, and in this case, what acid-base status would the patient be in. Although even if you didn't diagnose this patient, you could probably interpret what the acid-base status should be. But moving onwards. Now then, what is the diagnosis in this patient? Well, if we look over the vignette, she is an 8-year-old girl, she's young, and additionally, she has increased thirst and frequent urination. What are the 3 ipsias of diabetes type 1? Polyuria, polydipsia, polyphagia. So she already has 2 of those things. Polyuria, frequent urination, polydipsia, increased thirst, and polyphagia is increased hunger. That isn't seen in this patient, but it can be seen in other clinical vignettes. And also one more important thing, nocturnuria. Moving onwards, they describe her breathing as deep and rapid. Now, deep and rapid breathing is actually Kussmaul breathing. This is almost it's highly associated with diabetes type 1. And additionally, the buzzy term, or something that should ring the bell immediately for type 1 diabetes, is the fruity odor off of her breath. Now, more often than not, this sort of vignette is associated with diabetes type 1, especially the fruity odor part. Now, all of these things combined would lead one to the diagnosis of diabetes type 1, especially her fruity odor breath. And the reason why she has a fruity odor breath is because the ketoacidosis she's experiencing, the ketone bodies is like, for instance, and most importantly, acetone, is being ventilated out of her lungs, exhaled, and in that exhaled breath, there's a high concentration of acetone as well as other ketone bodies. And so that acetone has a very strong smell. If you've ever smelled nail polish remover, that's acetone. And so that strong smell is what leads one to assume that there's a fruity odor being exhaled. Additionally, also look at her BSR. There's a BSR of 480 milligrams per deciliter. We could also probably run a urine analysis. There would probably be ketones in her urine, or we could also do a serum ketone analysis, and there'd probably be ketones in this patient as well. Now then, we know that she has diabetes, and a common complication of diabetes is diabetic ketoacidosis, which would explain this entire vignette. And another important part, she has abdominal pain. Abdominal pain is how diabetic ketoacidosis presents, especially in young children. And she also experienced it after a viral upper respiratory tract infection. That's also important because states of stress like surgery or illness or infection, after that period of time, patients who were normal before might suddenly experience the symptoms of type 1 diabetes mellitus. An episode of stress causes an increase in glucagon and cortisol, which can suddenly cause the body to go into diabetic ketoacidosis. Now, moving onwards with the laboratory findings, finally going into the explanation why C is correct. Well, first of all, let's look at the pH of this patient. Now, we know the patient's pH is 7.12. So the normal is 7.35 to 7.45. If that's the case, then this patient is in acidosis. So the pH is low. Now, we know the pH is low. What's the cause of it? It could either be a metabolic cause or a respiratory cause. If it's a metabolic cause, her bicarbonate should go low, whereas if it is a respiratory cause, her partial pressure of carbon dioxide should go up, because the more carbon dioxide that is retained in the body, the more carbon dioxide converts into carbonic acid, which would then cause the pH to go up. Now, if we look at this patient's bicarbonate levels, the normal being from 22 to 28, this patient has 8. That's severely low. So one can assume that the bicarbonate level, because the bicarbonate level is low, the patient is in metabolic acidosis. And additionally, if you also look at the patient's carbon dioxide status, it's 25 millimeters of mercury, although the normal should be between 33 to 45. Because of the rapid breathing, she's ventilating off more carbon dioxide. Because carbon dioxide is going down, carbonic acid goes down, and so this cannot be respiratory acidosis. In fact, this respiratory compensation that's occurring is actually, again, a compensation. So this vignette is basically a metabolic acidosis with respiratory compensation. Now, before we continue further, the first part of the question, high anion gap, what is that? All right, so what is anion gap metabolic acidosis? Well, a bit of a history lesson. Basically, older machines, whenever they would read blood, they could only measure certain cations and certain anions. And whenever you measure the cations versus the anions, right, there was always a gap. And the technicians and doctors used to think, hang on, blood has to be electrically neutral, otherwise there'd be a charge to it. So what's going on? And they found that this gap would always exist between the realm of 8 to 12 milliequivalents per liter. That gap basically referred to all the unmeasured anions in the body, like proteins and sulfates and all that extra stuff that the machine couldn't measure, like sodium, potassium, chloride, or bicarbonate. So they thought that was pretty interesting. And then when they also looked at this gap in acidotic patients, right, that gap would increase in certain patients. And so they thought, hang on, this can actually be used to diagnose patients. And so that's how this came about, anion gap metabolic acidosis, right? And that's pretty interesting. So now, what is the cause of anion gap metabolic acidosis? Well, at the crux of it, a very simplified explanation is that you're basically adding acid into the body. Just think that if you're adding acid into the body, there's going to be an increase in the anion gap. And if there is no, and in the other mechanisms, right, which cause a non-anion gap metabolic acidosis, you're not really adding acid into the body. You're basically increasing bicarbonate removal or excretion. Now, the causes of non-anion gap metabolic acidosis, again, I repeat, non-anion gap are numerous but fewer than anion gap. That's basically, diarrhea, renotubular acidosis, and certain drugs like acetazolamide. Now, moving on to anion gap metabolic acidosis, we have the very important Mud-Powell's mnemonic. Now, if we go through this real quickly, we'll understand what are the different causes of metabolic acidosis, common causes. For M, we've got methanol. U for uremia. Remember, high yield association. Uremia is caused by renal failure. They may not outright say it in the USMLE question stem that the patient has uremia, but they will mention that he has renal failure, and then they might ask you to extrapolate what acid-base disorder the patient's in. So then you have to remember, okay, he's in renal failure. That's uremia. He's got an anion gap metabolic acidosis. D for diabetic ketoacidosis. Ding, ding, ding. That refers to our question. This patient has a metabolic anion gap acidosis. Just a quick go through the other questions. P for phenyramine. That is a medication. I for isoniazid and F iron tablets. L for lactic acidosis, another high yield association. Lactic acidosis need not be associated with only exercise. It is also associated with shock because the tissues are not being well perfused. E for ethylene glycol, antifreeze, and S for salicylates or aspirin. Now, before we begin, how do you actually, if you don't have this mnemonic or whatever, right? How do you actually calculate the anion gap acidosis? Well, I did mention earlier in my story, right, that sodium, that the old machines used to measure certain cations and anions. Well, to calculate anion gap acidosis, you have to take sodium and subtract. You have to take the sodium amount of sodium and subtract it from bicarbonate and chloride, which in this case was 132 minus 8 minus 96, and that leads to 28 milliequivalents per liter, meaning that is well above our 12 milliequivalent acceptable range, meaning that this patient definitely has an anion gap metabolic acidosis. And as we mentioned earlier, the patient's bicarbonate is also lower than normal, 33 to 45, meaning that this patient also has respiratory compensation. All right, hope that was interesting, and I hope you learned something. Take care. Bye.